Ken Landau. Thanks for watching. Let's talk about Zulresso or brexanolone. This is the first drug approved by the Food and Drug Administration to treat postpartum depression. They approved it in March of 2019, became available at the end of June. Prevalence of postpartum depression is enormous. It affects about 12% of all women around the time of pregnancy. That's 1 woman in 8. And most women who have the condition aren't diagnosed, and those who are diagnosed tend to be diagnosed by the obstetrician, not by a psychiatrist. You can have several normal pregnancies and then develop postpartum depression, but once postpartum depression develops, it can reoccur in about 25% of pregnancies. Indistinguishable from major depressive disorder, we know that the only feature that separates the two is that postpartum depression occurs during the 3rd trimester of pregnancy or the 1st month after pregnancy. Now, some people would like to say that it can occur for the 1st year after pregnancy. It doesn't make any difference, really, because depression is depression whenever we make the diagnosis. And it's also important to realize that the most common cause of maternal death after childbirth in the developed world is suicide. Suicide linked to depression. So women should be screened for the condition, screened at the gynecologist, obstetrician's office, screened at the pediatrician's office. It's very simple for a woman to fill out an Edinburgh postnatal depression screening test form. It's a questionnaire, has 10 items on it, can be easily looked at and can tell if a woman has the problem. The risks for postpartum depression: previous depression, depression that occurs early in pregnancy, family history of depression, bipolar disorder, stressful event during pregnancy or medical complication of pregnancy or lack of emotional support, maybe alcohol or drug abuse. Actually, we have some terminology we have to discuss. So there are the baby blues. The baby blues occur in about 80% of all women shortly after pregnancy, a couple days after pregnancy. Lasts about a week or two and then goes away. No therapy necessary. Then there are the postpartum psychoses. These are extreme. They need psychiatrists. These are the women who suffer from hallucinations and paranoia and delusions. But most of the time, the problem is going to be postpartum depression. Typically in the 3rd trimester, 1st month after delivery. The symptoms are the same as with major depressive disorder: sadness, lack of enjoyment, difficult time thinking, hopelessness, feeling overwhelmed, having crying episodes, feeling numb and empty, inability to be comforted, sometimes with anger or rage or suicidal thoughts, sleep or appetite changes, loss of libido, and then thoughts of harming the baby, poor response to the child, poor response to the child's needs, decreased sensitivity to the infant, not caring for the infant, lack of feeding of the infant, lack of attachment to the infant. Those are problems that can cause the infant other difficulties as he or she grows, and that increases the risk for depression in the child. Well, unfortunately, the standard therapies available up to the present time for depression, for postpartum depression, any kind of depression, they take a while to work. They're not really quick. We have the standard antidepressants, we have psychotherapy, we have some other kind of therapies. But now we have this brand new therapy. We have brexanolone. And the question is it appropriate? Well, it's very difficult therapy to administer. You have to have it given in a facility, and it requires 60 continuous hours of intravenous therapy administered only through the risk evaluation and mitigation strategy that the FDA sets up. So at the present time, in September of 2019, it's available in 100 different facilities throughout the country in 55 of the top 140 major metropolitan areas. It has to be delivered in a hospital, an infusion center, a wellness center, a fertility center. So far, there are no psychiatry centers where the drug is administered. The drug has to have on site an EMT or a nurse or a doctor. It's given intravenously, first relatively slowly, gradually, then it's increased in quantity, increased up to a maximum of about 90 micrograms per kilogram of body weight per hour, and then slowly tapered off. Have to mix a lot of different bags. It's going to require a lot of medicine to get this 60 hours worth of therapy. Mix a lot of bags up first, keep them stored in the refrigerator for up to 96 hours, or maybe just keep them at room temperature for up to 12 hours. A 60-hour infusion is going to require 5 different bags. The bags are going to be hung at hours 0 and 12 and 24 and 46 and then 48. If you happen to weigh a lot, then you need even more medicine. It's given through a programmable peristaltic infusion pump for accurate delivery. Has to be given, start anyway, early enough in the day. Why? Well, because it can cause you to lose consciousness, so you have to be monitored. That's why you have to be in a facility. Now, you need pulse oximetry when you are receiving the medicine, because maybe you're not going to be breathing for a while. And that's an issue, obviously. And you have to be assessed every 2 hours while you're awake to make sure that you're not hypoxemic, have low levels of oxygen, haven't passed out. You can't be alone with your child during the time, because if you do pass out, you could harm the child. Can't engage in any activities that require significant mental alertness. Can't breastfeed. Can't breastfeed for the 60 hours while you're on the therapy, or for 4 days after the therapy ends. And with other antidepressants, there's always the issue, they seem to be able to increase the incidence of suicidal thought or ideation. Well, does brexanolone, does the Zulresso do that? We don't really know. Hasn't been around long enough, hasn't been tested on enough people. Now, we do know that 5% of the people who are receiving the medicine required an interruption of the dose or discontinuation of the dose. Most of the people fully recovered within 15 minutes to an hour. But when you stop breathing, when you don't have enough oxygen, or when you're unconscious, that's an issue. So here we have a condition where, let's see how the studies do. Well, they did 2 studies. One of them, they looked at people who had severe depression. Severe depression, on the Hamilton Depression Index, in these women, they had a score of about 29. That's considered severe depression. So on one study, in the 60-hour infusion, in the placebo, they improved by about 14 points, from about 29 down 14 points. On receiving the standard recommended dose of Zulresso, they improved by about 17.5 points, a little bit better than placebo. On receiving a lower than recommended dose, 60 micrograms per kilogram per hour, they improved by about 19.5 points, so even more than the higher dose. Well, at the evaluation, it seemed like over the first 12 hours, whether you got the placebo or the low dose, high dose, you improved by about 10 points. Then the difference showed up in between the doses, between 12 hours and 60 hours, and then after the stop of the infusion, there wasn't any change from 60 hours to 30 days. Well, what was the end of the therapy like? So after 60 hours of this medicine, are you cured of depression? No. You've gone from severe depression, chances are, to mild depression. Most of the women were still suffering from mild depression at the end of therapy, whether you got the high dose, the low dose, or whether you got the placebo dose. And as a matter of fact, the people who got the lower dose seemed to do better than the people who got the higher dose. Didn't seem to make any difference whether the women were relatively young, say less than 24, or whether they were over 25, what the race was, whether they were taking an antidepressant at baseline, what the timing was at the onset of the postpartum depression, during pregnancy or after, or whether they had a family history of postpartum depression. Then they did another study, and instead of having severe depression, where there was a smidgen of difference between the groups, they looked at women who only had moderate depression. Their Hamilton D score was about 22.5 rather than about 29. So they gave them 60 hours worth of therapy. And in the group that received the placebo, the score fell by about 12 points. In the group receiving the medicine, the the score fell by about 14.5 points. So they're statistically different. But was it important? Doesn't seem to be. And as a matter of fact, if we follow the women out to 30 days, surprisingly, the women appear to be equal. And as a matter of fact, if we look overall, the women receiving the placebo seem to do a smidgen, not statistically significant difference, but a smidgen better than the women who received the medicine. Now, while the women were on therapy, about 12 or 13% of them had to start taking another antidepressant, and even though the women were not supposed to be depressed before they entered the study, already 22% of them had been taking an antidepressant. Well, there is a significant issue when we look at the amount of medicine in the system, and is the amount of medicine correlated with the improvement? And it would seem that maybe it's not, because the women who received the higher dose, who actually had more medicine in their system, those women, if anything, did a little bit less well than the women who received the smaller amount of the medicine. Now, once the medicine is in the system, about 99% is bound to the protein. The half-life of the medicine is about 9 hours. Interestingly, the studies, even though they lacked really impressive benefit, these studies were designed by the company, the data was interpreted by the company, written by the company, and the company even had employees who were listed as authors on the paper. And as a matter of fact, the clinical trials that I just mentioned, or phase 3 trials that they presented to the FDA, were not nearly as impressive as the phase 2 trials that were used to see if the medicine could be potentially used. Well, the side effects of the medicine are significant, and that's loss of consciousness or pre-syncope that occurs during the infusion, and it's not predictable. Actually, one woman asked if the drug may be able to make you sleepy, and then immediately slumped forward snoring. Well, if you're holding your baby, that's potentially dangerous. So the patient can't be the primary caregiver during the infusion. And 6 of the women who were on the study lost consciousness. Now, that's while they were awake. We don't know what happens while you're asleep. Doesn't seem like the loss of consciousness is related to the dose of the drug or the blood level of the drug or your body weight or how old you are or other therapy you're receiving. One woman actually tried to commit suicide associated with the medicine, attempted an overdose. Several women had to discontinue the medicine due to adverse events, that's syncope or somnolence or low blood pressure or fatigue, and even had infusion site reactions and extravasation of the medicine, even though they're getting it under the best, theoretically, the best of circumstances. In 2 of the cases, of the very few cases, the infusion pump malfunctioned. Other side effects and sedation and somnolence and dry mouth and flushing and dizziness and pre-syncope, pre-faint and vertigo. There's an issue of the sedation and the somnolence and dizziness being about 10% of the people who receive the Zulresso alone, but if you receive it in combination with an antidepressant, it's 15 to 20%, and if you happen to take a sleeping pill or an anti-anxiety pill, a benzodiazepine, along with the antidepressant and the Zulresso, the likelihood of somnolence or dizziness increases to almost 50%. Well, the chemical itself, brexanolone or Zulresso, that's a new molecular entity. It's not marketed for any other condition. It appears to work on the GABA A receptor in the brain. Actually, it's chemically identical to allopregnanolone, which is a compound that the body makes. Actually, the researchers at the National Institutes of Mental Health on their intramural research program in the 1980s discovered it as a metabolite of progesterone and deoxycorticosterone. Well, it seems that it acts on this GABA, which is a very important receptor inside the brain. It seems like the allopregnanolone is an endogenous derivative of the progesterone. It increases with pregnancy, peaks in the 3rd trimester, and after delivery falls. Well, how do women develop the condition in the 3rd trimester if it hasn't fallen yet? It's made by the brain. It's made in the cortex and the hippocampus and the amygdala. And there's a shift in hormones, that dramatically change after delivery. So the estrogen, progesterone peak during pregnancy, dramatically fall afterward. We have similar kind of change in the thyroid hormone. The dose of Zulresso is meant to get the allopregnanolone concentration back to what it was in the third trimester of pregnancy. That's why we go through the initial titration so that we can get some tolerance to the sedation, and then you taper it afterward so you prevent the withdrawal reaction. And actually, we don't even know that it really works on the GABA receptor because some new progesterone receptors were recently identified. And actually, the drug, the allopregnanolone or the Zulresso, seems to work more at this progesterone receptor site than at the GABA site. And it actually might be with upregulation or downregulation of the GABA receptor. So we really don't know how the medicine works or if it works. It seems like if you have mild to moderate liver, kidney condition, it's okay to take the medicine. If you have severe kidney problems, you can't take the medicine, not because of the medicine, but because of a solubilizing agent that's in the medicine that you can't excrete, metabolized through the liver, but not through the major drug metabolizing enzymes. It's keto-reduced, or it's added to some glucuronide or sulfates, eliminated through your feces or through your urine. The company actually is moving to make the medicine available in an oral form for major depressive disorder. So far they say it's effective and well tolerated. They think that the drug makes their company worth about $9 billion. They have an oral micronized progesterone, by the way, that increases the allopregnanolone levels. When the drug was first evaluated, it was thought of as an anti-seizure medicine, especially for seizures related to the menses, catamenial epilepsy, maybe for refractory status epilepticus, or even for essential tremor. Cost of the medicine? You won't believe it. The cost of this medicine is about $7,500 a vial. You need 5, and it's going to cost at least $34,000 for a course of therapy, for that 60-hour therapy. That's just for the medicine alone. And I called a pharmacy recently, and they said that the price was $8,940 a vial. So for 5 vials, that's about $45,000. $45,000 for a medicine that's been tested in a relatively small number of women and doesn't show really dramatic results? And even then you only go from moderate depression to mild depression, or severe depression to mild depression, and that requires you to be isolated in a facility for 60 hours so you get this intravenous medicine that might knock you out, might decrease the amount of oxygen in your system. I'm not sure I buy into this medicine. What about IV ketamine or Spravato? That recently was approved by the Food and Drug Administration for treatment of resistant depression. Question is, would that work in this situation? It hasn't been studied as far as I know. But certainly the Zulresso seems to be less than overwhelming. Anyway, that's my opinion. Thank you for watching. If you enjoyed the show, please tell a friend. Maybe you subscribe so you'll get updated when we post a new show. Anyway, I appreciate your interest. I'm Dr. Ken Landau.